Hi guys, my name is Yana Pogosian and this is my week 6 presentation on a SOAP note. My clinical site, I'm following Miss Kelly Manda. She's a family nurse practitioner of 3 years, and we are currently doing all of the clinicals in the family practice clinic. Now the brief description of my case. The client's initials is CD, and he's 78-year-old white male with the Medi insurance. He's married. The reason I was super excited about this case because this patient we had to go and see in the hospital setting in Sherman Oaks Hospital. Because he over the weekend got hospitalized with some symptoms. And when my clinical site came, I got there super early and they were doing rounds in the hospital and they invited me. So I was super excited to go back to the hospital. It's been a minute since I've been there. So now this patient is a 70-year-old man, was seen in Sherman Oaks Hospital for routine rounds and follow-up. His HPI is, he's known to our clinic for over a year. He was newly diagnosed with prostate cancer and with spinal cord compression, status plus decompression. He had thoracic and lumbar spine cord compression status post-surgery. He also has a paraplegia, acute back and right femur pain, acute toxic metabolic encephalopathy, subacute right occipital lucinar ischemic CVA, severe sepsis due to acute UTI, AKI and ATN due to sepsis, and history of GI bleed, anemia of chronic inflammation. Previously in fairly good condition. Over the weekend, he was presented to emergency room with complaints of severe back pain that he rated 10 out of 10. In AD, they did his UA and it showed 1+ bacteria, 1+ ketones, and 500 leukocyte esterates. The symptoms showed that he has a cystitis. He was started on Zosyn, 3.375 grams IV piggyback every 6 hours in AD, and admitted for further sepsis workup. Because of his age and his past medical history, the hospital felt that they needed to work this patient up. Today, he was seen in a hospital room on a 3 North for follow-up and to discuss plan of care in the hospital and plan to discharge home and what's the plan for this patient overall. His ROS, when we saw him, he had no fevers, chills, reported he had severe back pain, 10 out of 10 yesterday. Today reports pain tolerable at 3 out of 10. He denies any eye changes, any vision changes, drainage, or pain. He also denies any chest pain, any cough, sputum, dyspnea, or wheezing. Denies trouble swallowing, nausea, vomiting, and so on. His GI, he had 0 symptoms, denies pylorrhea, nocturia, urgency, burning, or pain on urination, hematuria. He did have a Foley catheter in place. When we were seeing him, it was draining cloudy urine. The reason the Foley catheter was placed is because of the urine retention. That is where we're working up. Let's see, he had no skin issues, no neurological or psychiatric issues. Endocrine was within normal limits, and he is not allergic to anything in terms of medications and environmental factors, but he is allergic to gluten. So past medical history is CAD, COPD, depression, DJD, prostate cancer, renal vein occlusion, thoracic and lumbar spine cord compression, status post-surgery, paraplegia, acute back and right femur pain, acute toxic metabolic encephalopathy, acute right occipital lucinar ischemic CVA, severe sepsis due to UTI, history of GI bleed, anemia of chronic inflammation. He did receive all of his immunizations in the beginning of this flu season in October. Surgeries, he had spinal decompression on 8/2020. He also had PCI of RCA on 3/2019. Right hip replacement was back in 2018, and tonsillectomy 65 years ago. Now he resides with his wife at home. She is primary care for him. His vital signs during our visit was within normal limits. His oxygen saturation was 94% on 2 liters nasal cannula, and pain was 3 out of 10. Now, for his lab results from this morning, it was WBC 6.05, HNH 10 and 27.9, platelets 264, sodium 136, potassium 4.4, BUN creatinine 23 and 1.70. CT scan of the pelvis without contrast showed cystitis, abnormal wall thickening with enlarged emplacement perirectal lymph nodes or masses not excluded, moderate bilateral pleural effusions with adjacent atelostasis, which explained why he had shortness of breath and was put on oxygen. For MRI, brain without contrast shows metastasis within the cervical spine and clivus, subacute infarct in the right occipital lobe. MRI of lumbar spine without contrast showed diffuse osseous metastatic disease, spinal stenosis, most evident in L4 and 5 with compression to both existing L4 nerve roots as well as both exiting L5 nerve roots at L5 and S1 to S1. There's likely an extramedullary extension of tumor within the right neural foramen of L5 to S1 and L4 to L5. MRI of thoracic spine without contrast showed status post posterior fusion from T5 to 11 and diffuse osseous metastatic deposits. He was tested for COVID and he was tested negative. Now, on the exam, it was within normal limits. We didn't really see any abnormalities with him. Now, for the differentials, we considered acute prostatic cancer with mets to spinal cord, which it was new, and if he didn't come for this hospitalization, we probably would have never found that he had metastatic cancer. He was initially diagnosed with prostate cancer back in July of this year. So next differential diagnosis was acute sepsis due to UTI. Acute back pain, subacute stroke, and severe protein malnutrition. So for acute sepsis due to UTI, we continued patient on cefazolin, 1,000 milligrams IV piggyback every 8 hours for UTI, and we discontinued Zosyn because his cultures came back. We continued to monitor repeated. We ordered to repeat the cultures in the morning. Urology recommended urodynamics as outpatient to confirm neurogenic case of retinol with Dr. Desal upon discharge and fully in place to help with retention. Subacute stroke recommended ASA and statin therapy. However, giving family concern with recent GI bleed, was going to hold off until follow-up with cardiology. MRA was not done per wife's request, and neurology consult was ordered. Acute prostatic cancer with mets to spinal cord. We have ordered the follow-up with oncologist, Dr. Posadas. We felt that he needed systematic therapy, and we started patient on Degarelix with loading dose today at 240 milligrams sub-Q times 1 now, and then maintain with 120 milligrams sub-Q every 4 weeks. We wanted to see if we were able to stage disease, so we ordered CTC, CAP with PO or IV contrast, but we are waiting right now for renal function test for this patient first. TC99 bone scan was ordered to see the disease progression and return to clinic post-discharge within 4 weeks for follow-up. For the acute back pain, pain control, and pain management consult today. Severe protein malnutrition, prealbumin is still pending. Nutrition consult and regular diet is tolerated by the patient. DVT prophylaxis, of course, because of the hospitalized situation, is heparin subcut. So for this patient, for the Gene Watson theory, I use the provision for supportive, protective, and or corrective mental, social, spiritual environment. Being a hospice nurse and this patient being with a metastatic cancer and severe decline, we did go over palliative care and hospice care and the differences and what are the options for this patient, what kind of services they will be getting, and so on. We involved social workers and spiritual advisors to help to determine whether the family would benefit from this kind of service. So I felt like this is very emotional subject for this couple, and wife is in a huge denial, and she was crying and she was very emotional. So she really needed a lot of emotional support and being there with her. So being a hospice nurse, I mean, it kind of comes as a second nature. So I felt that this family really needs services like that and help them to get through the disease process so the wife can actually enjoy being with her husband versus worrying about what to do next and what to order and where to go and so on. So hospice services do provide huge amounts of support to families at the end of life. That doesn't really mean that the patient is right now dying or something like that, but it does promote the quality of life for these patients. So I felt like this case was super sensitive for me, and it was very close to my primary work that I normally do. So that being said, that's my case, and the note is attached. I hope everyone has a great day, and let me know. I look forward to our professor's feedback. Thank you. Bye.